Fantastic. Well, I'm going to go ahead and open it up to the floor for questions since in case there are any. Yes. Forget that.
Good morning. Thank you very much for the information you've shared. I'm Lisa Fitzpatrick. I'm a local physician and epidemiologist, and I live in a food desert. So we've done a lot of work looking at challenges with food, and I haven't heard you all talk much about food literacy and why that's important and impactful. Some of the things we're learning include people are getting their food. The cheapest food is from the corner stores and the fast food restaurants. So how can we partner with them on, or have you thought about any of these things? And then finally, a lot of the interventions, I think someone mentioned, are short term. I think we have to change the palate of the community, because even though we offer fresh fruits and vegetables at a lot of different sites and institutions, people often prefer the food that tastes good, that they can grab right away. So I would just love some feedback about that and how we can incorporate this knowledge into the interventions.
So I'm happy to take that one. So there's a couple different things. So the first piece of it, the food literacy piece, is incredibly important, right? So when we started our program, that was a high priority for us to really make sure that we were very focused on that. As we have patients come into the program, that's why one of our pillars is education. We spend a lot of time in that space. And I think, to your point, making sure the healthy food that we provide, because in many cases it's different from what our patients are used to who are using the services. We need to make sure that we have good recipes and we have all of the other things that come with that, and we're educating them because it is a lifestyle change. But I think the downstream impact is that as we've partnered with the food banks and as we've partnered in local communities and we've stood some of these facilities up in food deserts, what's happened is that it's actually raised the quality of food that's being delivered to other food pantries in that area and other food banks. So we're already seeing this downstream community impact. Our Central Pennsylvania Food Bank partners have done a lot to really increase the numbers of fresh fruits and vegetables they're bringing in and then redistributing outside of our program. But you bring up a great point. There's a lot of work to be done in this space. And in one community, we had 42 food banks that were actually in a very competitive type of relationship, which was something I was really unfamiliar with how to kind of deal with. But we really navigated through that. They now have a common intake process. They're sharing resources. They're better aligned. But all of that takes time. And to your point, really speaks to the foundation.
And just to follow on to that, it's not an unfamiliar sort of criticism of food banks or really the food industry generally that we're not doing enough to encourage people to make the right choices or have those healthy choices even available to people where they need them. And so that is one of the key things that we've baked into our strategic plan for us and our 200 member food banks, is to really focus on foods to encourage produce, protein. All of that comes with significant challenges. I mentioned the challenges around sort of cost and dealing with perishable and foods and foods that need to be refrigerated or frozen. But that is a really high priority for us, and it is something that we are working with the federal government on. A lot of the food we get through the federal government is high quality vegetables, protein, and other perishable goods. So we're trying to get there, and I think we've improved our quality, our food quality offerings. But another issue is also sort of, you got to get people to eat it, right? So again, it's partly the sort of choice issue. So we're doing education and other things, but it is, I think, the partnership between the health and the sort of food community and encouraging those sort of partnerships together. And again, hearing something from your doctor tends to get people's attention more than sort of hearing it from anyone else.
Well, I echo what my fellow panelists have said, but I really think nutrition literacy is multifactorial. So one thing is basic education on how to eat healthy. But then you have the lens of, how do I shop and eat healthy on a budget? So to your point, you live in a food desert. Your only option is the corner store. Well, they may not have fresh produce, but there's, eat this, not that. There's certain choices you can make. Another lens to look at it is chronic conditions. A lot of times you've got diabetes, so you have to eat a certain way, or you have heart disease, you have to eat a certain way. And so, I think you have to think of all these kind of different lenses, and then one more lens you have to look at is sort of being culturally sensitive. So is it a Hispanic diet? Is it, different, cultures and ethnicities have different diets that you also have to factor in when you're thinking about shopping and eating healthy on a budget.
Try to address two of the topics. So one, I agree with the sort of nutrition literacy issue. I think almost all good food insecurity interventions do have some component of education or, what do you do with the food? I will say we've done a fair number of focus groups and it's not an uncommon theme to hear, yes, I know what I should be eating, I just can't afford it. The healthy food is just more expensive than the cheaper food and would do that. That's what people say. It may not necessarily be what people do, but I do think, we need to think of this all together and sort of remember the sort of affordability issues as a key component to that. But I think it's clear that nutrition education, and then to the extent that it's part of a chronic disease management program, diabetes self-management or something like that, the specifics need to be in there. To the sort of corner store, sort of local, and questions around healthy food retail issues. There is a pretty significant body of literature around interventions to try to improve the healthfulness of offerings in corner stores or sort of mobile fruit and vegetable purchase options. I do know at least two cities, or probably more, but both in Philadelphia and San Francisco, there actually have been some local policy initiatives that enable corner stores that themselves are often not operating on huge margins to do some infrastructure upgrades, like have refrigeration facilities to actually be able to stock produce and not have it go bad before they're able to sell it and things like that. And I know of two researchers, one was a former colleague in Boston, one in Baltimore, who've done pretty extensive work in trying to work with corner store owners to get them to offer more produce and sort of address the barriers that the owners see to being able to offer that. So I think there is work going on there. Clearly more needs to be done, but I think these are all part of the multifactorial way we'll have to address these issues, and that there's not a silver bullet.
Great, thank you. Next question.
Hi, Daphne Delgado, Trust for America's Health. I'm fairly new to the nutrition policy lens of things, so forgive me if this question is kind of elementary or naive, but it seems a lot of the work that I've been coming across on a federal level is kind of getting to this issue of quality versus access, and there seems to be a lot of competition between the groups that I've been encountering on we don't want, on that issue of quality versus access. But I'm really heartened to hear these examples where, there's not a competition between those two. So, in the last panel, Dr. Shukayr kind of gave his top 5 policy recommendations. So I would love to hear from you if you guys have some top line policy recommendations that you think are high impact that kind of get to this issue.
I can certainly start with one. I think at minimum, shore up and ideally expand SNAP. It works really well. There's a lot of good evidence for it across the whole spectrum from prenatally up until older adults. It's a very efficient program in terms of the amount of dollars put into the program that actually reach the people who are eligible. The dollars spent tend to go back into the community and have economic money multiplier effects. And so I think of SNAP really as sort of the preeminent food insecurity intervention in the U.S.
I would agree. Part of a core component is people get involved in our program is the first step is that they sit down and meet with our community health worker to make sure that they're optimizing their SNAP benefits. So that's a really critical piece of our program. I think the other thing too is from a sustainability standpoint, how do we think differently about even the benefits that we're covering? Because we often will cover benefits for a lot of things that are, in the treatment arm, and we don't even think about that. But thinking differently about how we cover benefits in the prevention space, I think is equally as important. And it cost us about $1,200 a year to feed a family of 4. When you look at Rita and the amount of savings that are there, and even some of our other patients, we've had $160,000 a year savings on a particular patient. It's really changing the mindset to think, how do you get upstream of this, even from a benefit coverage and reimbursement standpoint as well?
Well, I concur with SNAP being the number one opportunity, but beyond that, we are a big payer, and so I think a lot about benefit design, and so in terms of supplemental benefits for addressing food insecurity on Medicare and Medicaid plans, up until really this year, food was not considered related to health or health outcomes, and so it was explicitly excluded from being covered as a value-added benefit. But now with things like the Chronic Care Act and the work that's happening with CMMI, with, as I mentioned, VBID and SSBCI programs like that are beginning to allow us to experiment with benefits around food delivery, grocery delivery, things like that, I think are big opportunities.
Yeah, I would definitely agree. I would say SNAP, and increasing the SNAP benefit. It doesn't come close to really covering what a family needs to really eat on a day-to-day basis. It's supplemental. It's in the name. And it's not really pegged to something that's a realistic evaluation of what the cost of food is. So I would say the first thing would be increasing the SNAP benefit, certainly not erecting more barriers to being enrolled in the program or to eligibility. I would say going the opposite way, making it easier to get enrolled and stay in the program. There were a few things in the Farm Bill that actually, on the Commodity Supplemental Food Program, which is a small program that serves seniors with boxes, they actually increase the time once you're enrolled that you stay eligible for the program before you have to re-enroll, because every time everyone has to re-enroll, tons of people fall off the rolls. So I think looking at some innovations around in that area. I mean, the same thing for other programs that serve the same population, Medicaid, Medicare, the Medicare savings programs. The Medicare savings programs, if you're enrolled in a Medicare savings program, you are far more likely to be also food insecure. Let's find a way to link up those things. First, let's get more people enrolled in the Medicare savings programs because they're dramatically they're under-enrolled. But also let's find a way to link these benefits up so that people are able to sort of one-stop shop for them. I would say in terms of coordination between the charitable food sector and health organizations, certainly there are HIPAA barriers and there are issues there. So they range from the small to the large, coding for food insecurity, various other things along those lines to help sort of coordinate the ability for charitable organizations or community-based organizations to partner with the healthcare industry more efficiently. Chair's prerogative to add three things about access. I was going to add two things about access, but now I'm going to say something about data because I don't want people, as they're thinking of sharing data between community-based organizations and healthcare, to think that HIPAA is a hard wall. It's actually just designed to protect people, but one of the P's in HIPAA is portability. And when the person wants their data shared on their behalf, it can be. So it is possible to work through it. But two access issues that would be interesting for you all to know about. One is, again, leveraging technology through processes like you're doing in North Carolina at the state level. When somebody enrolls in Medicaid, there's some eligibility and enrollment checks that are being done to see if they're eligible for other social care programs. We've done that in Louisiana for a number of years to match between Medicaid and SNAP to ease that access to enrollment. The access to the food, to the first question for you all to be aware of is that recently the USDA announced a pilot to allow online retailers to take SNAP benefits so that food could be delivered. And that may be an interesting way for us to start thinking about access beyond I go to a location, but more in the way that some of these food as medicine models are, like Seth's work, it goes to the person. So interesting policy options, Daphne, that are being tested that may make access more streamlined for folks. Okay, next question.
Hi, I'm Joanne Lynn from Altarm's program to improve elder care. I'm really grateful for this research. It helps fuel the advocacy for better food supply. But I wonder if we shouldn't have a strategy to make it outrageous to be able to do this research. It ought to be it ought to be unacceptable. I'm focused right now on the More Than a Meal study, in which a third of the people in 8 cities that had more than a 6-month waiting list for home-delivered food, after having been assessed to need home-delivered food, were randomized to get nothing. We would not be allowed to do that study on prisoners. We would not be allowed to do that study on children. Why are we both allowed to do that study on old people and find it tolerable and publishable? Why isn't that the stuff of NPR News and outrage? That there should be, in some cases, 2-year waiting lists for food. It seems that we need a strategy to get beyond kind of our research base. We have a research base now, and get the community to see that you can't actually have a functioning community with a fifth of the people not getting food. It seems it's every time the candidates talk about the right to health care without the right to food and housing, it just is galling to me. Isn't it galling to others? And shouldn't we have a strategy to make it just outrageous to have waiting lists for food?
Do you mind? Yes. Can you talk about design?
Sure. I mean, well, we do have a strategy. We're obviously not there yet, but part of our sort of vision and our strategic plan is to make hunger unacceptable in America. And I think part of the issue is people don't see it. They don't know that their neighbor or their child's classmate or their child's teacher is struggling with hunger. They don't know that it exists. And again, there's a tremendous amount of shame and a tremendous amount of stigma attached to the issue. And that might be part of why people don't know. But I think it is inconceivable that we have more than 40 million people living in this country with hunger. That is totally outrageous. And I think that it's hard to break through in this environment because there are, a litany of outrages to look at every day. But I think that, we're trying to break through, but we'd love to partner with you to try and make senior hunger in particular more visible, because it really isn't. Children are the people who are most likely to be food insecure in every single county across the country, but it shouldn't be acceptable for really anyone to be struggling with hunger.
I agree with what you just said. I'd actually like to address the research component of what you mentioned. I think research is actually a really challenging thing for us as we develop our portfolio, in that you mentioned randomizing a group that gets an intervention versus a group that gets nothing, right? That is unethical, right? So you could approach it the way, other clinical research is, where there's, current gold standard. So you have access to SNAP, you have a food bank, you have whatever, and you're comparing that to that plus an intervention. So that's maybe how I'd approach that. But even internally in our organization, we struggle a little bit with, we had a meeting with our management team, and we have all different perspectives. And, some people want to take an innovation approach to food insecurity. Test something really small, feasibility, then you scale it, and you kind of rapidly iterate. Other people are, well, the only way this is going to be sustainable is if you have, really solid, validated evidence published in a peer-reviewed journal, do a randomized control trial that takes 3 years, right? And so they're polar opposites. And we have to answer both audiences, because we need to move at the speed of business in our case and getting ROI and proof points and things like that. But we also have to have proof points for the scientific and the medical community as well. And so how we thread that needle is very delicate. We essentially need to do both, but it's a challenge finding that balance.
Yeah, I would agree with Andrew. We ran into similar issues and concerns even with our fresh food pharmacy program. So, when we started that, initially tried to keep it pretty specific to the diabetes population, because we already did the back end research to understand what the impact would be, and that's where we felt that we would be able to demonstrate the best value so we could continue to expand to all those other populations. So we're expanding to, we're now open to any chronic condition, because we've kind of proven it in that diabetes space, but there's still that constant pressure to get to that next level of proving it. We've been able to prove it with the data that we've done internally, but moving into those other, I think more sophisticated research models is imperative, but it was a a challenge for us, to be honest, because people would walk into our pantry that didn't meet the criteria but had a need. And so we had to reassign and figure out how we're going to do that. And, how do we help all of the patients in our population who are dealing with hunger. And so we do have, to your point, there's a prescription program, but there's other services and there's other strategies to try and help. It's not perfect, but it is a challenge.
And I'll just sort of second Andrew's point around the way you want to do research design in these cases. I'm not familiar with the particular study you were referencing, but I'm not aware of a lot of studies that truly provide nothing for people who are known to be food insecure or facing a nutritional need. And I think this gets to the what question you're trying to answer. If the question you're trying to answer is like, should we address food insecurity at all versus no, then maybe in terms of answering that question, not that it would be ethical to do this, but maybe in terms of answering that question, not addressing food insecurity would be one arm of the study. But I think what really we're trying to answer is like, what is the best way to address food insecurity, where you're usually comparing different approaches, some of which might be the current usual care approach versus a new innovation. Some may be sort of truly comparative effectiveness studies where comparing two different innovative approaches. But I think if you're framing the question as what is the best way to do this, then there needn't be the concern that people aren't going to at least have some option of benefit, because you're really only studying things that you think may be of some benefit to folks. So I would encourage folks to try to frame it more in that direction, so that anybody who participates in one of these studies has the opportunity to benefit from it. And I can speak personally, I would not want to be involved in any studies where people are truly getting nothing.
Thank you. Next question.
Hi, Larry McNeely, American Diabetes Association again. I love the policy discussion a couple questions back, and loved all those thoughts. But one of the issues that I know is foremost on a lot of folks' minds is child nutrition, both at the state, federal, and local level. We have a situation where, you want to think about public health interventions that work. WIC works. School meals, school breakfast in particular, works. Summer meals work when you get kids to them or find some other support. Those are gaps that can reduce the broader population risk. I'm interested in how we make those type of things part of the conversation. Right now, it's a situation where they're all in one bill. The chairman has said it's going to be budget neutral federally. Similar story in a lot of the states. You got to rob one of them to invest in the other. So I'm interested in how research shed light, how stakeholders' voices can shed light on that problem folks are facing here.
Thank you.
Yeah, we're engaged pretty heavily with the committees in their consideration around child nutrition. Again, it is, you don't want to rob Peter to pay Paul in any of these situations. And that is, I think, certainly what the anti-hunger community in general has expressed and made clear. I think, for us and from a Feeding America perspective, our top priority would be to expand access to food in summer for kids, whether that be sort of at a meal site or where those sites are not available in other situations. And it's a struggle, though, because, again, the dollars are sort of where do they come from? And there aren't any great candidates within that bill. So I think, it remains to be seen. I know that the chairman and the ranking member are having those conversations, and I think that is consistent, that sort of position is consistent with where they are, too. So I think that's the good news with respect to the outlook for the bill, whether it can proceed with any great improvements that will really dramatically impact access to food for kids in summer, or breakfast after the bell, or getting more kids eligible for school meals, generally speaking, I think remains to be seen, because all those things we all know cost money. And if we aren't willing to invest in it at the federal level, then I don't know who has the money to make that happen. So I agree with you and share your concerns.
Interested to hear some of the folks who don't live in that space comment on this one.
So I certainly can't comment too much on the nitty-gritty of the specific bill, but I do think from a research perspective in a larger way, one way to, I think, help address this, I think, is to really try to understand what the health impacts of programs to address, say, food insecurity or other health-related social needs are, because then I think that once you understand what those health impacts are, then that opens you up to be able to have a broader conversation around what healthcare interventions you pay for in some ways. And so some folks were talking earlier, if you're doing new cancer drug development, you get the biology right, you get the clinical effectiveness right, you establish safety and efficacy, you bring it to market, and then down the line there's a discussion about paying for it or it just gets added to formularies or becomes standard of care or something like that. When you don't know what the safety and the efficacy of a food insecurity intervention, for example, is, then it's hard to make those cases. But if you do know that, then I think you can start having conversations around, out of all the possible medical interventions we want to pay for, which ones have particular impacts and do it that way. And so I do see a role for broadening the research base to be able to say these are the expected health impacts of, X, Y, and Z policy or intervention program or something like that, and be able to put that in the language of things that we already pay for or sort of make decisions in that way. So I think it helps if you believe that there can be a rational decision-making process around these things, it helps to have it informed by the research base. So that's sort of a role that I view for myself and for the research sector of the field of having, is to kind of put these interventions on the same foundation as other interventions that have been successful in having financial support.
We have just a few minutes, and I want to allow you to ask your question. I don't know if Stacy, if you're in line also. Okay, so let's, if we don't mind, move on to the next couple of questions. Are you in line too?
Hi, Dave Bliss, Northwestern. I guess this question is a little bit more directed toward Dr. Renda, but in general for the panel. I'm interested in this issue of private payers sort of working to address social determinants, and I'm wondering, how a private payer that works with a lot, say, when you talk about addressing social determinants and primary care and behavioral health and collaboration and screening, how do you do that with providers, clinicians, organizations where 10% of their patients have this payer and 20% are Medicare and 30% are that private payer? How do you do that? How do you say collaborate without really angering these people who have this sort of fragmented reimbursement environment where they have all these sort of different masters they're answering to who they might look at more adversarial way than and less of a collaborative way?
Well, the short answer is carefully. But it is a challenge, particularly when we work with primary care doctors, because unless they're in a value-based relationship with us and they're accepting fee-for-service, they often have 10, 20, 30 different payers that they're accepting from. As 5 years ago, my answer would have been different. 5 years ago, my answer would have been, we don't really work with those physicians that much. But now, as part of our bold goal strategy, it's working with the community. It's that old theory of the rising tide raises all ships. And if you're influencing the environment, if you're influencing families and networks, you're going to improve the patients that we're primarily responsible for. And so when we go work with physicians, we will actually try to get them to adopt, for example, integrating screening for food insecurity into their EMR. Not just for our patients, but for everybody, because they're not going to do it just for ours. If they're going to do it at all, they're going to do it for everyone. And so, teaching them how to adopt that screening and referral mechanisms and interventions and things like that, it helps our patients, it helps everybody else. But our patients are friends with the other patients, and they're related to them, and, it's all this tangled web that we weave, but we have to do that.
So I would just piggyback on that. We actually, when we started to go down this path, we spent a lot of time determining who the targeted population was, and we made a very strategic decision to open this up to any community member. So within our fresh food pharmacy, we have Highmark patients, we have Capital patients, we have anybody can attend, our doors are open, because we saw this more as a community strategy to help stand up the health of the community. And quite frankly, we're an integrated delivery system, so whatever we do here, we see the benefits on a decent percentage of that population, and we have the data and the analytics on enough of the population that we feel like we can move it forward. I think that the other thing you have to think about, especially in our market, is that high mark patient may be our patient tomorrow, right? And so this is more about long-term sustainable health. And when we do the programs, we also focus on the entire family. So kids can come and attend the education program. So getting to that, next generation type of conversation, it's about, even as a healthcare or a payer kind of philosophy, just thinking about it differently and thinking about it as the community and the consumer first. And then everything else we just hope will kind of fall into play, and everybody will be able to demonstrate the impact that will allow payers to cover it, and then all payers will say, yeah, this makes sense to do this, and there will be collaboration there.
And that sure does complicate the science. We have 2 more questions. So if I could just go over here, and then we'll end with Stacy, and then we'll have lunch.
Thank you. I want to probe a little bit on the point that Dr. Berkowitz made, which was it's really important that we understand the relative impact and cost of alternative ways of addressing a particular need. But it feels to me like that presupposes that we've agreed that that's a need that needs to be addressed. And so I worry that if we put our focus there, despite the kind of ethical conundrum that arises when you do randomized controlled trials that test an intervention against what is the standard of care, which is no investment in that arena from the payer, for example. Are we going to be providing the evidence that the different decision makers and stakeholders need to actually assess what the impacts are?
I may not be fully understanding what you're saying, but so what I took it to mean is if you're in sort of a comparative effectiveness situation where you're trying to choose between 2 different ways to address a problem, then that presupposes that you've decided that that's the problem that you should try to address. If that's what you're saying, I think my response is, my view is the body of research on the harms associated with most of these health-related social needs is pretty robust, and I feel pretty confident saying that these are problems that are worth trying to address. And so, in my view, the scientific next step is about learning the best ways to address them. I'd be open to maybe alternative viewpoints about whether these truly are things that we should try to address or not. But my view is that whether they should be addressed is somewhat settled, but it is unsettled how best to do that. But maybe that there's a further discussion there.
Great, thank you. Last question.
Comment and a question. Thank you for this very informative panel, and the questions have been great. I do really appreciate the ethics question. This problem, food insecurity, discharging patients home to starve after we've spent hundreds of thousands of dollars on their cancer treatment. I mean, Seth, your cancer example is a real live example every day in our hospital. These are humanitarian crises, and those of us who are on the front line practicing medicine, nursing, social work are morally distressed by these problems. So in our institution, a hospital chaplain came to me and another doctor 10 years ago and said, people are starving at their children's bedside. We reached out to the Greater Chicago Food Depository, and with the help of medical student volunteers, in less than 3 months, we had a hospital-based food pantry, and now we have 7 of them. 24/7, 365, self-serve, no prescriptions, no barriers, and guess what? Our hospital employees and sometimes our house staff use those pantries. When I asked my question before, I thought living wages might come up as one of the things health systems might start doing in their conversations also with business leaders to address the housing problems and the food insecurity problems. So I'm putting a plug for that too. And we've never had any clear evidence to support the idea that people who don't need free food are stealing from the free food pantries. So I really needed to say that out loud. And then my question for you is, in your work, we've encountered many people who are starving, and without without the food from the self-serve food pantries wouldn't be able to make it through their child's hospitalization or care for their child when they go home. And yet, I cannot tell you, I don't know the actual number because the denominator is hard to know when you're not prescribing the thing. I mean, I think we prescribe things so we can count them, which has value in some cases, but many very low income, very hungry people have volunteered to give back to the pantry. They bring food back when they can. They come to, unload the trucks and stock the pantries. They support our advisory boards. And so I wonder whether any of your efforts have engaged people who've been food insecure in advocacy efforts and linking them so that they can be the voice of this problem and be partners so we do ethical research, which I believe, Seth, and really I do believe the field is conducting ethical research, but I'm
When you
interested in your
answer,
ideas.
everybody gets 10 seconds because we're already past time. That's all you get. And if
I'll
you keep
answer
talking, I'm going to talk over you.
Really
Go.
quickly. So absolutely, our volunteers are largely people who are participants in our program. And actually, we most recently hired one of our graduates to teach our evidence-based diabetes self-management program because it's really designed for lay people. And he also does some of the recruitment for our program as well. So it's absolutely comes full circle.
Yeah, and we have a really strong effort to bring people with lived experience here to Washington to talk to lawmakers. It's really impactful. We've sponsored training programs at the Food Bank of the Southern Tier in New York. They had a Speakers Bureau program where they taught people how to speak. It's hard work. These are people who often have had trauma in their lives, and they've never been on a plane. There's a lot of anxiety that goes into it. So there's a lot of effort that goes into it, but it is so worth it, and it really empowers people to be telling their own story rather than having someone tell it for them.
Thank you. Anyone else?
So I don't do a lot of advocacy work, but we do include participant perspectives in all of our prospective study design. So we don't design studies without getting that input.
Fantastic. I want to thank you guys. We're going to take a break now. We have lunch. It's available for purchase on the 3rd floor. We'll be back here promptly at 1:15. Please join me in thanking the panelists, and thank you all for your questions.